This is a 48-year-old gentleman who had underwent lab fundoplication in 2017 for GERD symptoms. There are no records of previous manometry, and as per the patient, a previous manometry was not done. Now, patient presented with post-fundoplication history of reflux symptoms, no dysphagia. He has significant weight loss of 15 kg. And endoscopy was done which showed an intact wrap with no evidence of distal esophagitis. Therefore, he was planned for an high resolution solid state manometry, followed by a 24-hour pH study. This is the high resolution solid state manometry of this gentleman, which systematically analyzed. We can see the upper esophageal sphincters opening and the contraction starting. We can see that in the contraction zone of the esophagus, after the peak contraction, in the distal esophagus, we can see multiple peaks of strong contractions happening. And these contractions are very strong so that the contractions are multi-peaked like a saw tooth. This was present in 6 out of 10 primary position swallows. 10 primary position swallows were done, and all the 6 had this similar pattern. In this swallow too, you can see multiple peaks of vigorous contraction of the lower esophagus, which represents a hypercontractile esophagus pattern. Apart from that, when we look into the lower esophageal sphincters and the IRPs, which is very important in this case of post-fundoplication case, we can find that the lower esophagus sphincters are opening adequately and the resting pressures of the lower esophageal sphincters are not high to call it as a tight wrap. What we predominantly see in this is an hypercontractile esophageal pattern with multiple contraction in the distal esophagus. The bolus clearance checked by impedance, the Z, that is the pink color, we find that there is bolus clearance into the stomach. After complete analysis, we find that out of the total 10 primary position swallows, 6 swallows had hypercontractile contractions, and the DCI, the highest DCI was found to be 55,682, which is more than the maximum of the upper limit DCI, that is 8,000. Also, we have to make sure that there is no other criteria that satisfies achalasia cardia. In this patient, the median IRP was 7.5, 7.9, which was less than 15 and normal, and bolus transit was present and it was intact, and hypercontractile contractions were present, which is strongly suggestive of hypercontractile esophagus with multiple peaks suggestive of jackhammer esophagus. Due to the background of previous fundoplication, to make sure there is no too tight wrap, we did an oral barium which showed no holdup of oral contrast, oral barium, and there were multiple tertiary contractions in the mid and lower esophagus. Chicago 4.0 classifies hypercontractile esophagus as a rare disease, and it classifies with 3 types, where the first one is a single peaked hypercontractile swallows, where there will be only single peak following the maximum contraction, that is, and the total DCI will be more than 8,000. And the second type is a jackhammer with repetitive prolonged contractions, like in our case, and this is the most common type of hypercontractile esophagus, the most common type of jackhammer. And the third type, there will be hypercontractile swallows with vigorous LES altered contractions will be there. So our case highlights an rare case of jackhammer esophagus, and this also highlights the importance of doing an manometry, proper manometry, before taking up any patient for fundoplication or for GPOM or GERD procedures. Many times, patients with GERD symptoms may have other esophageal motility disorders like IEM, ineffective esophageal motility disorder, or rarely like our case where there can be hypercontractile esophageal contractions like jackhammer esophagus or achlasias. Therefore, any patients who are taken up for GERD procedures should undergo high resolution manometry before doing fundoplication or endoscopic GERD procedures. And this is the highlight take-home message of this case presentation. Share to others for sharing the knowledge.